Hi, and welcome to the next set of slides for Clinical Anatomy 1. What I'd like to talk about next is palpation. I kind of alluded to it a little bit when I talked about surface anatomy in the second last slides. Palpation is an integral part of what we do as massage therapists. Palpation, remember, means to touch. I'd like to talk a bit about it because I think it's very, very important. You will also, in your consolidation lab, be actually performing palpations on certain structures for your marking scheme for your practice consolidation lab. So, when we think about palpation, it plays a couple of roles. The first, though, is physical examination. So obviously, when I talk about surface anatomy and understanding that when you look at the surface skin, having a sense of what's underneath there are three parts to a physical examination. One of them is just looking, seeing what the body looks like. Does it match up to what we consider to be normal? Listening to the patient talk about issues they have, whatever that may be. But the third thing is palpation and actually touching the patient and getting a feel for it. One of the reasons why we want you working with different students all the time throughout the semester is so that you get a better sense of what different feels there are to each human being. If you touched the same person all the time, you would never get a sense of how someone's tissues may feel entirely different as compared to someone else's. So this is the reason why you're going to be partnered up with somebody new and different all the time, so that you start to gain the knowledge and experience of the cross-section of ways a same tissue may feel when we start comparing it between one patient and another. So when we think about anatomy in the normal sense, I'm going to talk about bones and the pictures on the screen and maybe the odd video or whatever it may be. I'm here talking. What does that relate to? So why know anatomy? Well, we have to think of something called clinical anatomy or applied anatomy. And what this is, we're looking at body structures to help us. And it brings together regional and surface anatomy, stressing clinical applications. So by knowing anatomy, and it helps you to clinically make decisions as to what's going on. So we say that this involves the reversal of thinking as compared to regional anatomy. So instead of the direct attachments of a muscle and the action, we look at what would happen if the muscle wasn't there or the muscle wasn't working. So by me telling you that a muscle has an attachment A and attachment B, and it does this movement, when we're looking at clinical anatomy and the application of helping a patient, it is the knowledge of what a muscle does that helps us that if something is not functioning right, we know that under normal circumstances, muscle A would do this action. Well, the fact the patient can't do this action starts to get us thinking about that maybe that muscle A is the problem. Palpation then is the physical exam in which an object is felt to determine its size, shape, firmness, or location. So I did talk in A&P class, and I think I'll be coming to it here a little bit as well. And in your lab, you start talking about the T's of palpation. And it is something that you have to, when you touch someone, you have to be thinking with your fingertips. So the word palpatio, it means to touch, but it's more than just touch. When we palpate someone, it is about perception. So some teachers will say it's like looking through your fingers under the skin, which is a very good analogy because that's in fact what you're doing is although your hands are touching and you're using the sense of touch, your brain is also interpreting what your fingers are touching and coming up with a picture of the feel, the texture, the temperature, and so forth. The thing is, the sense of touch is in the brain. So it's about the fingers feeling something, sending a message to the brain interpreting what that means. So you can imagine then that I could have two people touch the same thing, and because of a various amount of reasons, each person may represent that differently. So we have to start standardizing you guys so that if I say to you that something is tight, you can feel it and touch it as tight the same. So that's what the whole practice consolidation labs are about. is you practicing by touching all the time, getting a sense of what's under there. Maybe initially you touch a partner and you say to yourself, I think that muscle's really tight, and you ask your instructor, is it tight? And if the instructor says, no, that's a bone, or yes, that's tight, it starts to help you build a knowledge base as to what you're feeling. As you may have learned, touch is a result of special organs. Sorry, I forgot to correct this slide, but basically, as I've said, touch is a result of special organs found in the dermis of the skin. And it is something that we need to help you get away from, and that's using your eyes, for example. So it's not unusual for a massage therapist when they're touching a patient to have their eyes closed so that their eyes see better. In fact, I do it quite often when I'm working with a patient. My eyes are closed, trying to get a sense of what's underneath. So you are basically feeling with your brain. And so due to this new sensory input, how does one determine what it is they are touching or palpating? So how do you know? How do you know that when you're touching a patient, you can say, oh, that is longissimus thoracis, or oh, that is the head of a rib? How do you know that? You know that because I know you've worked really, really hard to learn your anatomical structures. So this is one of the big reasons why you need to work so hard to know your anatomy. Because when you do touch someone, you better have a pretty good sense of what's under there that you're touching. In fact, there was a case this summer where there was a Major League Baseball pitcher. He was treated by a massage therapist who thought the structure they were touching was something that needed some work. And in fact, what they did, they actually did damage to a nerve in his arm, and he was unable to pitch for about 2 weeks. So this is why it's so important to know your anatomy. So you have to take the knowledge of the anatomy and you integrate it into your neurological sensations of the therapist from the client's body. So you touch someone, you've done the work in class, you can start to help put 2 and 2 together to build a picture for yourself. Will you be wrong sometimes? Absolutely. I'm wrong sometimes. Most of your teachers are wrong sometimes. That's just what happens. But the more you do it, the more experience you gain, the better you will become. So we can say that we are looking with our fingers and hands. In massage therapy, we say there are 5 T's of palpation. So when I am touching someone, I'm trying to get a sense of the temperature of the tissue that I'm touching. The texture, is it firm? Is it soft? Is it wet? Is it dry? Tenderness, how painful is it for the patient when you touch it? What is the tension in the muscle, and meaning tightness, and what is the tone? Tone is set, we'll talk about this a bit later, but tone is a preset by the brain that keeps the muscle in a somewhat constant state of contraction. So what does this mean to palpation, these T's? There is a reason why this next statement is in bold letters. Not only are we palpating anatomical structures, but we are also assessing the tissue at the same time. This is known as intelligent touch. It drives me a bit mad when I talk to people who go and see massage therapists who, for the entire time they're treating the patient, don't shut up and keep talking. And I don't know how they can be a good therapist, because if I am truly assessing through palpation, I should be concentrating on the feedback my hands are giving me to come to conclusions of what I think is going on with my patient. So you are, in sense, you are using your hands as intelligent touch to get the feedback of any one of these 5 T's to assess your patient to better help them. So what is it we actually palpate when we're touching our patient? It could be a number of things, and a lot of them all at the same time. We palpate bones and their individual landmarks, so any lumps, bumps, grooves, indents, whatever it may be, of bones. We can palpate ligaments. We can palpate the muscle belly, and then running out to their edges, we can palpate their individual tendinous attachments. We can palpate for specific areas of circulatory pulses, like the one on your wrist, your neck, your carotid artery, so forth. Fascia, would be a long talk about fascia in the other class, the A&P class, but fascia seems to be the number one with a bullet discussion right now in massage therapy, that we think that this is what we affect the most, is a type of tissue that we find in the body. And there can be other structures as well, sometimes particular nerves as an example. How do we do this? It's about being slow, not about being fast. So it's important that the therapist's mind has the time to interpret and make sense of the sensory input they are receiving. This goes back to experience and knowledge. It may take you longer to figure out what something is as compared to one of your teachers, which would make complete sense because they've had years of experience of touching structures and you haven't. So don't get frustrated if you don't feel certain things right away. They will come with time. The number one question I always get is when Brian says use appropriate pressure, what does that mean? And it's hard because part of appropriate pressure is what's good for your patient. So if you're touching a patient and it's too much for them, then obviously that's too much pressure for them, for the patient. So it's not quite as simple as saying, oh, touch with this amount of foot-pounds of pressure to be for the best palpation. But there is a couple of rules we'll get to here in a second. It's imperative that the therapist's fingers are sensitive to the client's tissue that underlie them. However, to qualify a specific pressure is near impossible. One way to gauge light pressure is to press on your eyelids and feel your eyeball below. And so if you get an opportunity here while you're listening here, just close your eyes, gently touch your finger to your closed eyelid, and roll your eye around and see if you can feel your eye rolling around. See if there's anything that kind of suddenly sticks out or disappears. So the question is, how much pressure should you use? How much is too much when looking for deep structures? That becomes the other issue. If you're trying to palpate something that's relatively superficial versus something that's deep, the pressure is definitely going to be different. But again, how does your patient feel about it? But as a general rule, if the fingertips blanch, so if you just take your finger now and push it on the table, if you notice the nail bed turn white, if you push firm enough, that's probably too much pressure because you're actually cutting the sensory parts of your finger off. You won't get the good feedback. In some cases, underlying structures are contracted to recreate a firm resistance. As a general rule, if you're trying to palpate something superficially, you can make it stiffen up, whether it be through stretching it or having it contract. But if you're trying to get something underneath that muscle, so you're trying to get to deeper structures, as a general rule, you want to try to make those superficial tissues as soft and pliable as possible. Generally speaking, you guys are all going to use too much pressure initially, but through time and practice, you will get better at it. The optimal pressure, as I said earlier though, is to use whatever pressure is appropriate to the circumstance of what's going on and to your client's feedback. So the quality of palpation, it relates to the client's comfort. It is best achieved by the therapist using their fingers. This means finger pads, not fingertips. So on the pads of those fingers, you have lots of sensory neurons that get lots of feedback. And the more you practice, the more sensitive those fingertips will get. Next question I have is, when do we palpate? And the only answer is always. The moment you touch your patient anywhere on their body at any part of your treatment, you are palpating. You are constantly getting feedback as to what you're feeling, feedback as to where you are, and a sense of what structures are underneath your hand, our hands, at any given moment. Whenever we are contacting the client, we should be palpating. This not only is true during the assessment phase of the session, but also during the treatment. So please, we just don't mindlessly work our hands across someone's body. We have intelligent touch. We are paying attention to those 5 T's. We are paying attention to the structures. We try to pinpoint, is that a quadratus lumborum? Is that iliacus? Is that a lateral collateral tendon of the knee or ligament of the knee, and on and on and on. We just keep on going. So as an assessment, I refer to it, I just want to quickly go over this list. You will be getting this in your assessments class, but it's just, when I talk about assessment, I'm talking about trying to more formalize what it is you're touching to get a sense of what may be going on under the skin of your patient. So initially, palpation for tenderness plays no part in an assessment because referred tenderness is very real and can be misleading. Only after the tissue at fault has been identified is palpation for tenderness used. So when we use palpation as an assessment, we're trying to discriminate between tissue tension and muscle tone. We're also just trying to distinguish differences in tissue texture. We're trying to identify shape, structures, and tissue type, and see if there's any abnormalities. We want to see how thick it is and its texture. Is it pliable, soft, or resilient? Is there any swelling? We're looking for joint tenderness by applying pressure to the joint. Do we feel variations in temperature? So sometimes I'll touch a patient's sore elbow and also touch their normal elbow, their good elbow, to see if it's warmer on the bad elbow as compared to the other one. We want to touch and see if we can feel pulses of blood vessels. Are there tremors or fasciculations, which is kind of like a jiggly of the muscle? Is there any pathological states of the tissues in and around a joint? Is it too dry? Is it very dry tissue, or is it very moist, wet tissue? Is there any changes in sensation? So such as dysesthesia, which is diminished sensation, hyperesthesia, very sensitive, increased sensation, anesthesia, which is absence of sensation, or crepitus, meaning that when you move the tissue, it actually crunches and grinds and makes noise. So these are some 10 things to think about. I'm not going to be spending a lot of time on this, but you probably will be directed to this somewhat in your clinical, in your practice consolidation lab this coming semester. Thanks for listening, and that's the end of this slide set.